Well, welcome, optometric education consultants. This is our evening education, Cornea Copia by Dr. Joaquin DeRojas, who is a board-certified fellowship-trained cataract, refractive, and corneal surgeon. He earned his medical degree from the University of Pennsylvania, ophthalmology residency at Columbia University Medical Center, and cornea external disease and refractive surgery fellowship at the Johns Hopkins Wilmer Eye Institute. Dr. DeRojas specialized in cataract and lens replacement surgery, LASIK, epi-LASIK, and implantable collagen lenses. He is experienced in the treatment of Fuchs dystrophy and corneal swelling with decimated stripping, endothelial keratoplasty, and Dmacc. I've been working with Dr. DeRojas ever since I arrived at Center for Sight. He's a great friend and colleague and a tremendous surgeon. I'm honored to be working with him. I've seen his work. It is exceptional. And if people are in the area and are so inclined, he is a great referral source. He does tremendous work. So with that, I am going to turn it over to Dr. DeRojas to share his screen.
Yep.
And begin our presentation. So with that, Joaquin, please take over.
Yeah. Thank you, Joe, for the really nice introduction. And thanks to everyone for being here. It's a privilege to be able to talk to everyone about cornea, which happens to be my favorite topic, and all the related diseases, and a lot of surgical management is what we'll be delving into, just because that's what I deal with, but also how to screen these patients, how to work these patients up.
Joaquin, can you share your screen, please?
Yeah, let's do that. Here we go. Okay.
It's perfect.
Slideshow mode, there it is. Okay. So let's get started. I work at Center for Sight with Dr. Sika, and it's been a great experience here in Southwest Florida. And we'll go a little bit into sort of what I've been doing in the practice, how we work with optometry together as a comprehensive group. And that really comes into play with the first topic, which is going to be dry eye disease. Not just dry eye, but ocular surface disease. So here's the outline in general. We'll be talking about dry ocular surface at first. And this is really based off of a presentation that I did for our 30 plus optometrists at Center for Sight. So we can try to manage dry eye better before surgery, because we found that this was a big risk factor. But after that, we're going to talk about a little bit about refractive surgery, how I know which patients are candidates, which are not, and what are some tools that we use, corneal ectasia, and cross-linking for things like keratoconus, and when you should refer these patients. And then kind of going from front to back in the cornea, we'll also talk about some dystrophies, corneal edema, and some things we can do for that. Okay, so the first thing is dry and ocular surface disease. So like I said, this presentation is largely based on preoperative management before surgery, because we think dry eye management is so important to have right before these patients go get refractive surgery or refractive cataract surgery. But these principles apply for ocular surface management. And it's something that not a lot of people, everyone manages, but I think it's kind of the thing that no one really cares to manage too much, because it often goes undermanaged. So that's kind of why I'm bringing it up. And it's everyone. It's MDs, ODs, cornea specialists, retina specialists. Everyone is guilty. So here's the outline. Let me outline for the dry eye section. So we're going to describe the components of the precorneal tear film, establish the tear film instability as a core issue with dry eye in the preoperative patient. That's really the central thing, and introduce a protocol for assessing tear film instability, and then for optimizing it. And then after this, I'm also going to talk about a handout that I use that I encourage you can adopt it, that will make your workflow better when you're talking about all of this dry eye treatment options. So a little background, the precorneal tear film is the most important refractive surface of the human optical system. It has the largest index of refraction differences between the air and the tears. So it has the greatest optical power. This is why in our practice, which is largely a refractive cataract practice, this is so important for us. Ocular surface optimization is essential to ensure good outcomes and happy patients. I did an internal study here, which based on some patients who had had LASIK and advanced IOL surgery. And dry eye severity, once you take refractive error out of the equation, which we can fix, dry eye severity was the strongest predicting factor of patient dissatisfaction. And the most common complaint for dry eye was fluctuation of vision. So this is super important when you have these patients for your comprehensive yearly exam and they're saying my vision's bad. You know this already, but trying to tease that out a little bit. Why is it bad? Is it bad all the time, all throughout the day? Is it bad at the end of the day? Is it bad? Does it change when you blink? Does it change throughout the day? If the answer is yes to those things, they probably have a component of dry eye here that is worthwhile looking into before you send them to the, even before you send them to the surgeon. So the precorneal tear film, I like to start with this because I think I like to look at these layers and talk about how management relates to improving a specific layer. So you have the lipid layer on the outside, aqueous, mucin, the mucin layer produced by the goblet cells on the conjunctiva, that is what really sticks the whole tear film together. It's a very important layer. Aqueous produced by the lacrimal glands, accessory and main ones. Lipid layer produced by the meibomian glands in the eyelids. And that's why the eyelids are also a super important part for many reasons, this being one of them, of dry eye management. And we'll talk about that. And you have disruption in any one of these tear film components, you get tear film instability, which leads to poor and inconsistent optics and unhappy patients after surgery, but also in general, unhappy patients regardless of surgery. And that's why I think this talk is relevant regardless of surgery. So if you look at the colors here, we're going to talk about the components of dry eye disease and how they relate to the tear film. So in green, we have ocular surface inflammation, because it's in, my opinion, a lot of evidence that ocular surface inflammation does a lot of things, but primarily it affects the surface of the conjunctiva and cornea. It decreases goblet cell density, which decreases the mucin layer. Inflammation in general creates little divots kind of in the mucin layer, and the whole stability of the tear film breaks down. So inflammation is a super important part of dry eye. We're going to talk about aqueous deficiency. Patients that have Sjogren's syndrome, for example, or just age, you just produce less tears. And that's the big middle layer there. So we're going to talk about that. Meibomian gland dysfunction, moving to the lids. We talked about the meibomian glands and how important, why is this so important? Well, it's yellow because obviously it's the lipid layer, but it's super important for keeping allowing the tears to rest and not evaporate quickly. So that's why we talk about this layer and why this layer is important. And blepharitis is kind of a mix of the ocular surface inflammation and the meibomian gland dysfunction, because it's on the lids. It's right, the eyelashes are right next to the oil glands. So when you have inflammation at the eyelashes, guess what? The oil glands get clogged. So it's kind of a mix between these two. And we're also going to have to deal with that if we see it. The whole thing relates to tear film instability. That's why I think we should consider this the core subject as to how dry eye affects vision. So dry eye affects many things, patient discomfort and whatever, but I'm more interested right now in how it affects vision, given what I do. And that's how we're going to talk about it for now. And how these conditions are interrelated to each other. And the whole thing is a big feedback loop that needs to be broken. I liked when I was setting this up for our practice and trying to streamline dry eye care, especially in the preoperative setting, I tried to simplify things as much as possible. And I looked at the ocular surface inflammation, aqueous deficiency. I said, we can look at these things together as part of ocular surface disease. And we can look at blepharitis and MGD together as eyelid disease. And those are going to be the main distinctions when we talk about a simple protocol to follow. So this is the protocol for assessment of dry eye that I use. And I use this in the preoperative setting and also just when I'm assessing severe dry eye patients as well. And I think it's really a good protocol, like a diagnostic protocol, because it's simple. And simple is better. There are other parts of the eye that are more important than the tear film in other ways for the patient's health. I would say optically, the tear film is probably the most important, but but you want this to be streamlined in your practice. You don't want to spend hours doing dry eye treatments. Now, there are a lot of different diagnostic tools available. I'm going to talk about tear lab osmolarity because it's something we use. But honestly, you don't need a lot of things. You just need a good exam and some stains, some dyes, and a good exam. You can jump into LipiScan. You can jump into MMP9 testing, Inflamadry. You can jump into all these things. But if you stick to this core basic diagnostic tools, I think you're going to do great. And the other things are very much adjunctive, and I have nothing against them. And please include them in your practice. But at the very least, do some of these. So even this one I say is optional. Tear lab osmolarity, I don't always use it, but I'll talk a little bit about it. And that's going to be the first step. If you have it, I would say do this first before you instill any sort of drops. And this would be true for Inflamadry and for other type of testing of the tears themselves. So I would say do that first. And in the case of tear lab osmolarity, we want to gauge the total osmolarity. So as eyes get drier in general, the amount of sodium and osmolar concentration relative to aqueous is going to go up. So that's kind of the idea behind this. And if you look at the literature, how is this test positive? Well, the test kind of can be all over the place. So osmolarity greater than 308, I find that to be dry eye, and you'll get a reading that comes out when you put this thing right there at the base of the lower eyelid. But it can really be all over the place. And if the patients use dry eye drops or any drops in the last 2 hours, it's totally inaccurate. So I actually like, in one of the studies we did with, actually my wife is also an ophthalmologist there, Priya Matthews, at the bottom you see the reference. But one of the studies we did is we found that the difference between eyes, or the difference across multiple time points of osmolarity, is actually the strongest predictor of, or strongest correlate with dry eye disease. And that's because it makes sense. It's instability of the tear film. The osmolarity is going to fluctuate. So I think if you use this test in this way, it's very powerful. But obviously, if you have an osmolarity higher than an absolute value, I pick 308, but you can pick a little bit of a higher threshold. But I think this is a good threshold based on evidence, including our paper and our review that you could use. And I think, like I said, this test is really good for ruling in tear film instability, but not necessarily for ruling it out. I've had plenty of severe dry eye patients, including Sjogren's, that you put this thing on them, and guess what? They reflex tear. So now their osmolarity just went totally down. And if you go totally by osmolarity, you go, oh, this person doesn't have dry eye, but they do. So I would say it's a good test for ruling in tear film instability, but not ruling out dry eye. Okay. And I'd say this is an optional for our comprehensive eye doctors at our practice. I say this is an optional test. It's not necessary, but it can help. So do your testing if you're going to do it first. Whatever you're going to get, tear lab, whatever, LipiScan, whatever you're going to do it first. Okay. And now we're talking about the patient actually getting to the chair in the room that you're going to examine them. So I think it's great time saver to have your technician, or you can do it yourself, instill the fluorescein drop in the eye right away. Now there's some controversy. You want to look at a virgin eye. I understand that. In our setting, it makes a lot of sense. Usually I'm seeing these patients, they've already had an exam, but in a lot of cases where it's preoperative testing, I'll just have them instill the fluorescein drop. And the reason for this is because for fluorescein to really work, you need to give it time. And that's something that we often forget about. You really need 2 to 3 minutes. Closer to 2 is fine for it to stain all the little punctate epithelial erosions, or the SPK, to really stain all of those. You really need to give it time. And often we're rushed and we just we drop them, we look, and oh, it looks fine. And that happens all too often. So I think that's important. And that's why I try to do it even before. So as they're dropped, I'm reviewing their history. I'm talking to them about their symptoms. And then I look at the slit lamp once I'm done with that. So what are the things I talk about with the patient? Well, fluctuating vision, we kind of touched upon this already. That right there is probably the most sensitive test, in my opinion, especially in the preoperative setting. Burning, I start thinking of blepharitis, an ocular surface inflammation component. Excess tearing, it's kind of a contradictory if you think about it. Why would patients are like, I'm tearing a lot, so I don't have dry eye? Well, you may have dry eye and you're reflex tearing. There's an inflammatory component. Gritty sensation, again, probably an inflammatory component, no symptoms at all. So I get so many referrals, patients that they say, I didn't even know I had dry eye. And they have some of the worst dry eye I've ever seen, or ocular surface disease, because they're now neurotrophic. And that happens a lot to Sjogren's patients, or even just straight up neurotrophic keratitis, obviously. But you get this a lot, and you have to explain to them that they've lost sensation in their cornea. Red flags that I look for in the past medical history: advanced age, autoimmune conditions, sleep apnea. Patients that have sleep apnea that have floppy eyelids and use O2 cannula or CPAP, now they have an element of exposure keratitis, and that really dries them out in general. You're going to have a big problems with those patients. Red flags already come up. Contact lens wear, glaucoma drops, diabetes, ocular surgery history, and look at their meds. A lot of these psychotropic medications, anything anticholinergic, dries people out. Like allergy meds are another one, and menopause. So these are just things to look for. So any questions about history and symptoms, Joe, or can I keep going?
No, we're good.
Okay. So, and feel free to ask questions at any time, and we'll stop. So another thing I really like to do, and again, I make this optional because not everyone likes using lissamine green, but I find it really helpful because the cornea doesn't always light up, and sometimes only the conjunctiva does. And this basically represents devitalized epithelial cells. So when I do the lissamine green, this one, you don't have to wait 2 minutes. That's why it's later in the algorithm, because it stains right away. So it'll stain devitalized epithelial cells, whereas the fluorescein, we'll talk about what that does. But this is really, sometimes this is the only thing I see in Sjogren's syndrome. And that's why I use it. So this is kind of like my inflammatory. This basically represents severe ocular surface inflammation. And in these same layers of surface inflammation on the conjunctiva, where you see like the staining here in this picture, right? Severe staining, that's where there's going to be goblet cell loss. So that tells me there's a mucin layer deficiency and there's inflammation. So I find this to be a really helpful test. But again, it's optional for you.
Joaquin, so if I can interrupt, a question came in is, can lissamine green be used following sodium fluorescein? I mean, how do the two vital dyes work together?
Absolutely. I do it all the time. So I have my tech often, like if I haven't seen the patient yet, I'll just have them do a drop of fluorescein and and then take the little strip, go in the inferior fornix and hold it there until you see the green spread. So I put both on at the same time, but you don't want to put it on too early because then it can wear off, or patients will dab at it and they'll say, oh, my eye's green, and they'll keep dabbing it until it's not green anymore. So you don't want to wait too long. But this one can be done right beforehand, and there could already have been fluorescein in there, or you could do it at the same time. So I like doing them both. I kind of talked about the best way to instill it. And then it's nice. You want to look at this under low, just yellow illuminate, like regular illumination on the slit lamp. And if it's too bright, you might miss it, especially if it's some like more trace staining. So I like to look at it. You don't have to make the slit beam too slit. Make it broad and just look. So I have the patient, I say, look to your right and look to your left.
Let me find that.
So look to your right, look to your left. I look temporal, I look nasal conj, and I look in both eyes. It's really quick. It's one of the first things I do in the exam because I know that's already staining right away. So I can do it right away. And then I use the Sika syndrome scoring, so the Sika scoring system, I should say. The reference is below. I find it's really helpful because you basically you look at the temporal conj, you look at the nasal conj, you grade it from 0 to 3. And then after we'll talk about, you look at the cornea and you grade that with, based on the fluorescein staining. So it's simple. And basically what you'll see in my notes is just LG, and I'll talk about temporal 1, and I'll do like a /2. And that means that temporal it was 2 and nasal it was 1 or something like that. And then the left eye, same thing. So that's kind of like in this case, this guy would be, if this is his temporal side, then he would be like a 3-3. And it's pretty bad. So if there's significant staining, this is when I start, we're not going to talk about management just yet, but this is when I start thinking about an immunomodulatory drop or steroids, because there's a big inflammatory component here. So this is when I start thinking about like the Restasis and the Sika. We'll talk about that. And I should consider if I were to see this patient here, I would do labs. So either refer to a cornea specialist or even a rheumatologist. But you may want to just do some labs before you refer to a rheumatologist, which is what I do. And just some simple labs, an ANA. So basically labs related to Sjogren syndrome. There's about 4 that I tend to use that are, which is ANA, rheumatoid factor, anti-Ro, anti-lot. So there's like 4 of them. But if you're not sure, just maybe refer it out. Or you can email me and I'll talk to you about it. So that's the conjunctival surface assessment. And then by now, the fluorescein has had its time to work on the cornea. And we take a look. So I not only look at the amount of staining, but the distribution, because that's important. So I call them PEE. They can also be called SPK, although SPK technically refers to Tygason's disease. So, but it's okay. It doesn't, everyone uses it. It's fine. So I assess it with cobalt blue light, at least 2 minutes after. We talked about that. And if the erosions, one thing that I always stress is that if you have any erosions present at all, I mean, except for maybe a little bit of minor inferior, you have moderate to advanced ocular surface disease. You're not supposed to have erosions in your cornea. It's just, that's not normal. So that's actually kind of already moderate dry eye. So that's an important concept. And if I have central, like here, there's some central staining, or a confluent pattern, even if inferiorly, it almost like this, let's say this line is all like one color, there's no individual dots anymore, that's very significant. There's something going on here. All right. Inferior pattern, like in this case, I'm thinking of eyelid disease. Either they're not shutting their eyelid properly and then some element of exposure keratitis, or they have blepharitis, bad MGD. And that's usually the pattern you'll see, if you have inferior staining that's much more significant than central or superior. So all these things are helpful. And here, based on the Sika grading syndrome, again, this is 0 to 4 dot grading scale. Grade 4 is for if there's any confluent staining, like I mentioned, any staining in the pupillary area, that would be visually significant, or if there's any filaments present. So if any of those things are present, it's already a grade 4. And this is taken from that study, that grading scheme that I use. And again, I was saying, it says 3 here for the central corneal staining with fluorescein, but you get an extra point if you have any of these things. So that's why it's actually out of 4. That's the way I do it. And then you have the conjunctival staining here. So you can look at this and if you want to use it, but as long as you're looking, you're already ahead of the game. So corneal surface assessment continued. So in addition to the looking for punctate erosions, I'm looking at the tear breakup time and quality. So anytime you see this, and this happened within less than 10 seconds, that means that those tears are evaporating quickly. And a vertical streak appearance, sometimes you get, if this is more vertical, that's usually indicative of MGD. Why is that? Well, we talked about the lipid layer being what kind of holds the tear, preventing the tears from evaporating. So if you don't have a good lipid layer, that tends to be the distribution as the windshield wiper comes into play of how the tears evaporate, and you get that type of appearance. So it can tell you a lot. Other things, be aware of other ocular pathologies. It's not necessarily dry eye disease, but it's ocular surface disease that could be visually significant and cause symptoms. So EBMD or ABMD or map dot fingerprint dystrophy, whatever you want to call it, it looks like this. And it needs to be treated. And how do you treat that? Well, very similar to dry eye. It starts with lubrication. That's really an anti-inflammatory drop. So, but just be on the lookout for things like this. Exposure keratopathy we talked about, especially in those floppy eyelid patients or anyone with neurologic issues. Neurotrophic keratopathy, EKC, all these other etiologies that can cause staining or an irregular tear film. Just be on the lookout. And you can do this all within seconds if you follow this protocol. And finally, but often forgotten, is the eyelid assessment. And I think oculoplastics and cornea have a really strong relationship with each other because they interact very closely. And I work with our oculoplastic specialist a lot because the eyelids are so important for the surface. So the first thing I do, so I like this little mnemonic. It's actually abbreviated, but it's from the American Society of Cataract and Refractive Surgeons. They use this mnemonic to help you remember to do the lid exam. So look, pull, push. So obviously, you're looking at the lid, look for blepharitis, look for sleeves, all that. You're pulling, and that's to see if there's floppy eyelids and to see how the eyelids are reacting, like in this picture here. And then you're pushing because you want to see how those glands express. And that's my LipiScan. I mean, it's not great, but it works. And you're looking at the orifices of the meibomian glands, and you're pushing to see if you can express it. But let's talk about this. So the upper and lower eyelids, you're pulling, you're looking for lagophthalmos, and you're determining the laxity floppiness. Sometimes you look at this and it's floppier on one side and they have more staining in one eye than the other. Well, guess what? Ask them what side did they sleep on? It's probably on the side that's worse staining, and you got to talk about how to treat that. That's like an element of exposure keratopathy there. And do they use CPAP? That CPAP is so bad for this. It just blows right air into their eye. They already have floppy eyelids because they're on CPAP because they probably have obstructive sleep apnea. So it's like a double whammy, and these patients definitely should be on some lubricating ointment at night. Look at the blepharitis. It's amazing how often this is missed. Patients with burning eyes, it's just missed all the time. So just look at it, and it takes you an extra 2 seconds. Just look at the eyelashes. And if you see this, you got to treat it because it's an infectious risk for the cornea. It's causing the patient a lot of symptoms that they can't describe. No matter how many artificial tears you put on this patient, it's not going to help their dry symptoms unless you get this cleared. So that's Demodex. And MGD, so you grade that 0 to 4, and I grade the blepharitis 0 to 4. And again, look at this cheesy stuff coming out. I would call that grade 3 MGD. We'll talk about that. So grade 0 means that the glands are open and you express them, they're clear, like water. So like young patients, you might see that. Grade 1 is the expression is now a little cloudy. It's a little murky. Grade 2, now you're pushing on the eyelids and it's getting hard to get stuff out. But if you push hard enough, it comes out and it's kind of like yellowy, whitish, but it comes out and it's still liquid. Grade 3, it's now like a toothpaste like this. And these are the patients that I love getting for Ilux or these treatments for the glands, which we'll talk about because these patients really benefit, these grade 3s. Grade 4, expression is not possible because the glands are blocked or they're absent at this point. And that's where I think LipiScan and these other things can be helpful because you can just see how many of these glands are just absent. And just remember, going back to this theme, ocular surface and eyelid disease are present together 80% of the time. So Sjogren syndrome patients considered to be an aqueous deficiency mostly, and maybe some inflammation of the ocular surface. Guess what? They all have meibomian gland dysfunction. So they just go hand in hand. And that's why I think of all these things as interconnected. So that's that. That's the exam. So I think that if you kind of work this in, or even some of these things into your basic slit lamp exam with these two dyes or even just fluorescein, you'll catch a lot more stuff here, and it'll help the patients in the preoperative setting and also just in general.
So there's a question that came in. I think I let you go on because I wasn't sure where you're going to address it.
Yeah, sure.
So what is your standard protocol for treating moderate chronic blepharitis?
Moderate chronic. Well, we're about to go into management right now. So I'm going to introduce a protocol for optimizing the tear film in the preoperative patient. But again, this applies to all patients. But in short, we're going to do a combination of eyelid cleansing, cleaning, and that's going to be kind of my go-to. And then there's different ways of doing that. And then I may even consider some oral antibiotics in certain cases. So we'll talk about it. And that's exactly what we're going to do right now. So tear film instability at the center again. And we have all the components. And now we're going to talk about treatments. So ocular surface inflammation. Now we're going to start thinking of immunomodulatory drops. This is your Xiidras, your Restasis, your Sequas, your all those. And then especially in the preoperative setting or in really bad cases, I don't hesitate using a low potency steroid or even Pred if that's all you have, just to get the inflammation under control to allow these other agents to start working. Just breaking that cycle. So this is kind of what you're thinking for treating ocular surface inflammation. Aqueous deficiency, we all know about artificial tears, but you'd be surprised. There are many different, and you probably already know this, there are many different brands of artificial tears, and some are better than others, and some are really bad. And you kind of have to think about what artificial tears are you recommending. And that's something we've been doing here, because there are ones that are better than others. And punctal occlusion, this is something that we've talked about. It's a great procedure in certain patients with aqueous deficiency. You want to be careful when they also have a lot of inflammation to not just do punctal occlusion, because you can actually make the inflammation worse, because then you got all this inflammatory material building up. But in general, it's a really good way. It's just using the patient's own tears, and it's quick and easy if you practice it, and it's reimbursable. There's a lot of things about it that are useful. And we'll talk about that. And again, that's ocular surface disease. And then down here you have lid disease. So meibomian gland dysfunction. I do think, there have been some studies with mixed evidence as to how much omegas do, but I would say they work in about 50% of people. So I would say that why not just try it? They have other health benefits. So I just make sure patients are either, have fish in their diet, and if they don't, that they're taking some sort of omega supplement if they have plugged meibomian glands. Warm compress masks. I really like the masks. I know we always tell patients warm compresses, just get a cloth and moisten it, but it just doesn't work well. Usually the towel or the rag will lose its heat pretty quickly, and patients don't like to get wet. So I really like the microwavable mask. And then we have in-office lid treatments like the Ilux or the Lipoflow, these other things we can talk about. So blepharitis, lid cleansers. We'll talk about different, that's my main go-to. Obviously, if they have Dmacc, you're thinking more cleansers that have tea tree oil in them. So if you see those cylindrical sleeves, you want to make sure you have some element of tea tree oil potentially, but even Dmacc responds just to better hygiene. And I stay away, I'll talk about this, we'll go into more detail, or I use oral antibiotics, and I'll explain why I use that over ointments. So this is sort of the, condensing this whole thing into a 2x2 table of management. This is it. So this is how we're going to go through this. So you got mild and your moderate severe. And there's more nuances in this, obviously, but this is kind of like an easy thing you could like put on your wall in your exam lane, just to kind of remember it if you need it. Okay, so you have mild ocular surface disease. How are you going to treat that? Well, this is what we offer in our practice, and I've kind of tried all these out. I like the TheraTears because it comes in a big bottle. So patients that only need it like 2 to 4 times a day, this is like, it's not preservative free, but it's preservative free upon contact, and they last pretty long. I like them. They come in 15 ml bottles. So I do that for like patients that don't have terrible dry eye. The Retain MGD, I like. These are now, you're thinking about drops with mineral oil. So think about castor oil or mineral oil drops are ones that are going to replenish that oil layer when they also have mild MGD or moderate MGD. You might want to consider this. And I like the Retain MGD because it's preservative free, but this is where like Soothe XP works. This is where Sustain Complete works. So they all have elements of oil in them. So it's things to think about. But my absolute favorite drop so far has been the Oasis Tears Plus. And by the way, I have no disclosures. I don't work for any of these companies. I did a trial on a bunch of my severe patients, and I just found this drop to work really well because it uses hyaluronic acid, and it stays in the eye longer. So there are drops similar to this, and I'm not going to say this is the only one, but drops with hyaluronic acid, these drops seem to last long, and I really like them. So for severe patients, I do this. And I did a survey on the optometrists and the MDs in our practice, and just to look at, and it just shows you with a range of drops that they use, and that's just the way it is. And the preserved artificial tears. So I just don't think there's been a lot of research into looking at these over-the-counter brands and these over-the-counter products, but it's so amazing because it's what we give patients all the time. So I think it's worth just thinking about it a little bit. Because there are definitely brands out there, especially some of the CVS brand or some of not to call out CVS, but some of the generic brands that don't work very well or they don't last very long. So Now we go to moderate severe ocular surface disease, and we talk about how this is really determined by the ocular surface and eyelid margin exam, but tear lab osmolarity and other similar tests can be helpful. We already talked about the criteria for that. And remember, some of these tests are invalid if the drops are used within 2 hours of testing, any drop. All right, so immunomodulatory drops. So now you have at least moderate staining. So you probably have you can see some obvious staining on the cornea here. And you're thinking there's an inflammatory component. So now you're thinking, okay, well, this is the maintenance drop, I call it. So at least put them on this for a little while, try to get the inflammation under control. You may not have to jump to steroids right away, or you may want to also do this with steroids. It's up to you. But basically, I really like Sika because number one, it's a higher percentage of cyclosporin. I think it's better tolerated by patients in general, and it seems to work faster. And I think that's because it has the castor oil and the mineral, or it has one of the oils in it. So it works as a really good artificial tear in the beginning, and then even before the cyclosporin works. So I really like it. And Restasis is similar. It has that oily component to it as well. But I find it takes a little longer for it to work. If the patient's already on Restasis and they're happy, I don't change them. And Restasis is covered by more insurance companies. So, you can use either one. We also have this compounded Clarity C medication, which we use for patients that are cash pay. It just costs them about $50 or $60 per bottle. And there's Xiidra as well, which uses a kind of different mechanism, really a T-cell inhibitor, whereas the other one's a cyclosporin analog that's calcineurin inhibitor. So they're a little different, but the idea is that they both work on specific parts of the immune system to break the inflammation cycle. So that's what cyclosporin lifitegrast does. But in addition, I tend to use cyclosporin more because they have some additional benefits. They improve goblet cell function, actually, and they increase aqueous production, which is interesting. And that's probably just by breaking that cycle where you have a neurosensory cycle where the inflammation in the eye actually can overdrive the stimulation of the lacrimal gland, and then it actually starts desensitizing it over time, and you get decreased aqueous production. But this kind of reverses that, and you actually get increased aqueous production. And to my knowledge, that hasn't been shown with Xiidra yet. So I think in some animal studies it has. So I really like the cyclosporin. Started as soon as possible. The onset of action is about 2 to 3 weeks with Sika, and sometimes with Restasis, but it can take 1 to 2 months. And this is for long-term maintenance of tear stability. So if we have patients that are going to have surgery, they ask, when do I restart all this stuff? And basically give them about a week on their regular post-op drops, and then you can restart it after that. I really like dissolvable plugs, and that's why I put this in our protocol, because I've had too many issues with non-dissolvable. So I think silicone plugs are great if the patient has really bad dry and you size them correctly. But the problem is sizing. And I've had, about 1 in 10 patients won't like them. They don't like the feeling of it or whatever, and they'll want to take them out. And in my experience, and also worse than that, you have some patients that you'll just accidentally undersize them and they'll go all the way down and never to be found again. And sometimes they can cause canaliculitis and other problems. So I really like the dissolvable plugs. Quintessence and Oasis makes them. They go in, you don't have to really worry about sizing too much. You just got to get it in there. And they're easy, and patients hardly ever complain about them. So that's what we recommend. But they do need replacement every 6 months. So maybe use them as a thing to break that cycle, get the dissolvable plug in there, and then maybe after 6 months, I won't even need it anymore. So that's kind of my go-to, but I do use the silicone plugs. I just prefer these if I can use them. And now the steroid drop is recommended if there's punctate staining involved in the pupillary axis, especially now we're talking about the pre-op setting, because this is what throws off IOL calculations. So you really don't want any stain in the pupillary axis, and that's when I start a steroid. It works fast, and within 2 weeks, even a week sometimes, it can clear up the staining if you're also adding the artificial tears and all that. And that's why we use it. And I tend to use the lower potency ones. There are a lot of new ones coming out, but you don't want to go too low in the concentration either. So I kind of like the Lotemaxes and the Flarexes, but you can use what you like. So I don't really find the need of going more than twice a day. I think for the purposes of dry eye treatment, you could go 3 times, 4 times, you could do a little taper, but I tend to start them right away. And then I tell them, use this until your appointment when we recheck your IOL calculations. And if you're referring this out to a surgeon, you can say, use this up until you see them, and they can take you off of it at that point if they're happy. And if this isn't in the preoperative setting, you could use them when the dry is really bad and you just want to give the patient some relief, get some fast improvement in the signs of dry eye as these other things work. So that would be an indication for it. But obviously just make sure they don't have herpetic disease or something like that of the epithelium. So eyelid disease now, just going back to that question. So I kind of group these together, but obviously blepharitis and MGD don't always go hand in hand, but often they do. But I really like the mask we talked about. And for the lid cleanser, my recommendation so far is really the foam. I love the foams because the foam goes on the fingertip and they use it to kind of lightly brush their eyelash base. And I find this works really well. It's gentle. Sometimes with the pads, you see all these little gritty little cottony things on their eyelashes, and you can actually increase the inflammation if they rub too hard. So these are two of the brands I really like, the Steroid Eyelid Cleanser and the Aqueous Lid Scrubs. These things are changing all the time. There are other great brands out there, but my go-to is the foam, and I tell them to use it with their fingertip. And that's kind of what I do. And it has tea tree oil in it, so I also use this in Dmacc cases. But there are other good options, like I said. So, and this is how I instruct them to do it. I talked about that. Rough application of scrubs may worsen eyelid inflammation, so you got to be careful with those. And the other thing is, a lot of people talk about, what about baby shampoo? Well, I don't like baby shampoo because I think it's hard to get the concentration right. The patient is just, sometimes they put like the whole thing's baby shampoo. Sometimes they'll put like a drop to this much water. It's very hard to get it right. And even if you get it right, there have been studies that have shown that the diluted baby shampoo actually can decrease goblet cell function. And it just doesn't work as well. And there's evidence for that. So I like to just give them, I just say, pay a little extra money and get something that we know works, rather than some random baby shampoo where we don't really know the concentration you're using or the brand or anything like that. And I've had patients that I've switched from baby shampoo to a real cleanser or foam, and they've improved. So I don't even have this in my protocol, because when I'm talking about ocular surface disease, I'm not really talking about exposure keratopathy, which is from floppy eyelids. It's kind of a different disease, but they're related. But I just wanted to bring this up because if a patient has really bad staining in one eye and they're like sleep apnea and they have these floppy eyelids, something that's not on this protocol is you got to treat that, and you got to maybe do ointments at night or gel at night, and you got to do something to protect their surface of their eye from getting rubbed against their pillow when they sleep or getting exposed to the oxygen cannula air. So that's where you start thinking about some goggles or something like that, the moisture chamber goggles. It's a different disease, but I wanted to bring it up because that is part of the eyelid exam. It's something you got to think about. So when the blepharitis starts getting like really bad, and I want to improve it, I use oral antibiotics, and I use a Z-Pak because it's easy. These are patients, especially patients with rosacea. This works really well. If I see a Demodex, anything like that, because what Z-Pak does, it works well as a antibiotic, but it works even better as an anti-inflammatory for the lids, and it penetrates. Whenever you have skin tissue, drops are not going to cut it. I think, azosite, there are these drops and you may have some good results with them in some cases, but it's never going to work as well as something that goes through the bloodstream into the eyelids. So that's why I like it. And I also use doxycycline, which is what we traditionally hear about. But I do have reasons to believe that Z-Pak works faster and better. And it's also 5 days versus 30 days times 3 or whatever it is for doxy. So I try to prefer Z-Pak if the patient can tolerate it. And I tend to do about 3 to 4 a year. And this is kind of how, what I learned when I was at Johns Hopkins. We had one of the world's premier dry Sjogren's MDs there. And this is kind of how she introduced me to the Z-Pak. And the only thing you got to be careful about is refrain from prescribing this type of stuff to patients with any cardiovascular disease or arrhythmias. And usually the pharmacy will call you and tell you that if they're on like the Joxin or something for their heart. It's a theoretical risk that it could create an arrhythmia, but I've never seen that or heard of it. But yeah, just be on the lookout. And then the other thing is the omega oral supplements that we talked about. I do tend to tell patients to use them, but they take a lot of work. So if you're trying to don't to tell them it takes at least 2 months if it's going to work to help get that consistency of the myboom a little more fluid, I guess. So Ilux treatment, you could substitute this Ilux treatment for any in-office treatment, essentially, of the meibomian glands. I'll talk to you a little bit about why we chose Ilux. There are a lot of these devices out now, and there's more coming, and there's some that have certain advantages and don't have certain advantages. But I would say that the number one thing to look for with these devices is that A, you're heating the glands properly, and B, you're expressing the glands after you heat them. So any device that's not doing an adequate job of either is not going to work that well. And that's why I like the Ilux, because it's compact, it's portable, and also you heat it. You can heat the glands, and then right there, you express them. So you can do it all in one shot. You can even have a, yeah.
I'm sorry, Joaquin. Before we go into Ilux in detail, there was one sort of pressing question that came in from a member of our audience.
Sure.
Do you use oral ivermectin for Demodex? And if so, what's dosage? And can we use Soolantra on the eyelids?
Sure, I'll get back to you about that. But oral ivermectin is definitely being used in blepharitis. I personally don't, but I'll tell you what the dosage is. If that person wants to email me after, I'll just kind of consult with some of the doctors that I work with who use it, and I'll let you know. But I understand that it's usually like a dose for the whole week, and basically it's actually a very well tolerated drug. Unlike, I think, for cases of some of the initial indications for it, when you use the drug, there can be some side effects. But in the case of blepharitis, you're not killing any organisms. So it's actually very well tolerated, and it can work. I've never found the need to use it, to be honest, because I found that on my regimen, I get the Demodex out almost always. So I haven't yet needed it, but it's definitely a tool. So if that person wants to email me, I'll get into more specifics. I don't have the answer of the dosages off the top of my head. All right.
Perfect.
So, so that's kind of what I look for in a device to express the meibomian glands. And that's why I like the Ilux. I also like it because even you can get a technician to really train them well, and they can learn how to do this too. This could free you up in your clinic to do something else. My technician at this point probably does it better than I do. And obviously you need to know how to do it, and you need to do it too, but it's really cool. And you get this little viewfinder. I'll show you. So I really like it. I guess I am promoting it because that's what I use, but there are a lot of other good devices. The LipiFlow works, and we have that available too. IPL can work in patients that have like rosacea, a lot of telangiectatic vessels in their eyelids. It works pretty well. But again, remember, you got to express the glands after. The LipiFlow expression component is not that strong. So I tend to, if you're going to do it, I would probably try to express the glands a little bit, in my opinion, with a manual expressor, and same thing with IPL. So, and this is just a short video. I don't know if you can see it there, but that's just how I do the Ilux. It has a nice little viewfinder there, so you can actually see all that yellow down here, all that myboom. So it's nice because it's easy to use, and you really can see it in action, and you can see what that, what some of that looks like after. And you can show it to the patient. We charge about $495. I tell patients that I don't say it's a one-time deal, but I say that you won't need another one for a while, like maybe a year or so. If you liked it, you can do it again. If you don't like it, you don't have to. Because often I find that if I do this in combination with everything else, punctal plugs, steroid treatments, I do it all together as a package, then the patient gets relief and they're happy and it lasts longer. And then you tell them to do a mask after this for maintenance. They have to do maintenance treatment for this to last long. So I think with that combination, they do quite well. So I tell patients that, initiate the treatment ASAP. This is more for the preoperative setting. So we don't really have to get into that, but basically just start it right away, start a week after. And I tell them dry eye is a chronic disease. So it's going to be a lifetime of management. So we described the components of corneal tear film. We established the tear film instability as the core issue for dry eye, at least in the preoperative setting, but it's also a core issue in addition to discomfort, is tear film instability, which leads to visual problems as well. And we talked about a protocol to quickly assess the tear film and dry eye. And we also talked about a way of treating it using a simple algorithm. So this is starting to conclude here the dry eye portion of this talk. And why do we care about dry eye? Well, in our practice for our refractive surgeons, the reason they care about it mostly is because they want to optimize refractive outcomes and they want to improve the accuracy of the IO measurements. They want to enhance the quality of vision, especially with these premium lenses that use diffractive optics. You don't want to have diffractive optics at the tear film and also at the IOL. It's too much diffraction. You want to decrease the hand-holding visits with the postoperative care. We use a lot of co-management with our optometrist colleagues. And we want to make it easier on them too, because they're the ones that often have to deal with these patients when they're not happy with the results of a premium lens. And we want to offer new treatment options for you. And that's why dry eye is also important to talk about, to be able to offer the patient things like Ilux, punctal plugs, whatever you want. And you want to be able to set realistic expectations to the patient to understand they have two separate issues. You know, dry eye is actually another problem that they have. It's not the cataract. It's not their ERM. It's separate, you know, and that's important for them to hear that from you, because there's too many times that the patient comes and says, oh, I never thought I had dry eye. They just put me on these artificial tears. I didn't know I had dry eye. A lot of patients are just they don't know what's going on. And that's not good, because then they get it diagnosed later by someone else and they think that you missed it. Even if you didn't, you just have to tell them that they have it. So promote excellent outcomes and patient happiness. That's what it's all about. The end of this dry eye section, this is a really big list of things, but I just wanted to show it to you because I think what helps, dry eye treatment can get crazy because there's so much stuff and the patient gets overwhelmed very easily because there's so many little instructions and drops and this and that. So you want to have like a way to make it easier for yourself and a reference for your patient. And that's why I developed this sheet for our Center for Sight locations that not only tells them the instructions, so you can kind of like go to the next room and maybe have your technician go over it, or just have the patient read it. You can kind of briefly go over it. And what you do is you have these little check boxes and you check off the things that they're going to do. And then they have a reference to it. You don't have to keep writing it out. And you know, I like going through this, let's say they have some blepharitis, they have some MGD, I check this, okay? They have some blepharitis, I check this, okay? I tell them, just get one of these artificial tears, I check this, and then they look up here, okay, I'm recommending, we have the underlying ones are ones we have at our office, so just at checkout, they can get any one of these three. That helps us too, that helps them, it promotes your products. Anti-inflammatory drops, again, a lot of patients with dry eye, they're smart and they read a lot, sometimes for the worst. So give them something to read. You know, this is something to read. This is the second page. There's 2 pages because I use this as my ocular surface disease. So this isn't for everyone. You'd want to adopt your own thing, but I use this when I put a contact lens in, that I want to be an antibiotic. I want to make that easy too. So I just check this one off. That's not really for dry eye, but it's ocular surface disease in general. You know, this is some of my ointments I use. These are my oral antibiotics. And then these are some other treatments. So this is where I wanted to read about Ilux. So I checked this off. I said, next time, if your dry eye is not better, let's consider Ilux. If you have MGD, you know, still, and the warm coppers aren't working. So they read about it already. They look it up on the internet. And that really helps them be informed. Punctal plugs, all this stuff. Here's some stuff that's kind of like at the end of the list. So when my patients fail all this stuff and their dry eye is like really severe, they still have staining of the cornea, or they don't have staining, but they're still complaining, either one of these things, I find serum tears works really well for these cases. And you just have to find a compounding pharmacy that does it. But basically it's tears made out of the patient's blood, and they have all sorts of neurotrophic factors and all these things. They tend to work really well in some patients when nothing else works. So I jump on that if I have to. And this is for neurotrophic keratitis. So it's ocular surface disease, not dry eye. But if anyone has questions about that, you can ask me later about that. So any questions about any of these, treatments? This is basically everything I do in terms of treating dry eye or ocular surface disease. So any questions about management?
No, nothing has come in. You're doing great.
Okay, great. All right, so we got through that. That's the longest section. So these other ones will be a little less long. So refractive surgery, kind of switching lanes. So now the patients, hopefully their dry eye is well managed and they want LASIK. Okay, let's see what's going on. So when we talk about refractive surgery, we talk about things like LASIK, PRK, IC, and we also talk about lens-based options. And these are also considered refractive surgery, as you know, but is often forgotten. There's also SMILE, and there's other things that have come up. I'm not talking. We don't do SMILE at our practice. I haven't yet seen a benefit over traditional LASIK that we use with our current the most advanced laser. So I never adopted it, but basically there are different things in the pipeline as well. So but I'm going to talk a little bit about assessing someone for refractive surgery. So you can kind of tell patients right there and there if they're a good candidate, obviously. But if you're not sure, obviously just send them to the refractive surgeon. But be careful who you send them to, because they'll get refractive surgery no matter what, depending on who you send them to. So I'm sure you're aware of that already. So before any elective surgery case, perform a thorough evaluation and discussion with the patient. If you have topography or tomography, use it. You'll be able to screen things like keratoconus or just weird irregular stigmatism, where you start thinking about that. And you may want to, for example, do a contact lens trial, like even an RGP or something, just to make sure that you can get their vision better, that they have irregular stigmatism, and maybe that the contact lens is what fixes it and LASIK never will. So you want to have that information. You tell them, we're only going to get your vision better to what the glasses do, not what the contacts do. That's an important distinction here. Make sure that the patient has stable refraction. If they're 18, 19, and they're in medical school, and they're reading a lot, like they're probably going to become more myopic. So you want to tell them that we got to make sure that this is stable here, because otherwise it's just going to get worse later. Contraindications. There's ocular contraindications, keratoconus, obviously any cataract. When I get my presbyopes that come in for LASIK, if they have any cataract, they're not a candidate. Amblyopia, if you can get if they're happy with the vision you can give them with glasses, they're still a candidate. But if they can't see well with glasses, again, then they're not a candidate. So medical, these are the ones you got to watch out for, and the surgeon should be doing this. But just so you know, any autoimmune disease especially if it's not controlled, you can't do it. And there's patients that I've had, and this is kind of where the dry eye treatment comes into it. I've had patients with a really bad lissamine green staining. I had one last week, really bad lissamine green staining. And I said, let's do an autoimmune workup for Sjogren's. All right. And so last week is when we found out the results. But before that, so we had booked her for surgery, LASIK, and we said, it's probably going to be fine. We'll tune up your dry eye, but let's just get these labs. She finally got the labs done, maybe it was 2 days before her LASIK. And I checked the labs a day before at night, before I was going to bed, just to make sure all my cases were in order. And there it is. She had a positive lupus test. Canceled the case. This is a patient that her dry eye just didn't respond the way I thought it would, with steroids and everything. And I canceled her. And I'm glad I did, because there's too many reports out there of patients getting melts, really bad complications when they have either undiagnosed or not managed autoimmune disease, even some that have managed autoimmune disease, but if they're really managed well, they usually don't have complications. But there's too many reports of that, and you got to be careful. College of Vascular Disease, pregnancy, because, well, number one, the refraction is going to be all over the place. So you kind of want to wait. I wait at least 3 months after breastfeeding, usually, to consider refractive surgery. And medications, these are absolute contraindications. Discuss refractive goals, set expectations. If the patient's over 40 and they want LASIK, it would do me a big help, and I'm sure other surgeons would agree, if you did a monovision trial, because that's what I'm thinking of. Sorry if I spelled that wrong. That's what I'm thinking of when a patient's over 40. I want to start with monovision, because that's the only way they're going to get what they want, right? They want to be free from glasses. So you tune up their astigmatism, their hyperopia a little bit. You get them from 20/30 distance, or 20/25 distance, 20/20, but then they still can't read. And that happens. You see this too much. So they need to know that's not going to fix that. And if you do a monovision trial and they like it, well, that makes my job really easy, because then I just do that with the LASIK or with PRK or even refractive lens exchange. So that's a huge help, and you can kind of start the process with that. If the patient's on ambulatory surgery, the nice thing about LASIK, you can consider a touch-up. I usually wait about 4 to 6 months, because especially with PRK, you want to make sure it's really stable and that the dry eye sort of settled. And we do a lot of enhancement LASIK. There's another indication after cataract surgery. You'll find this sometimes that surgeons do this, and we put it as part of our package where if their refractive error is a little off after cataract surgery, we'll do a little enhancement. So LASIK, there's different types. And I think the cool stuff's coming out like topography guided LASIK, where it actually just, the goal is to shape the cornea into like a normal shape. In addition to changing the refractive error. That's really cool because you can get patients to get like 20/15 vision because their optics are just perfect. And that's what the new machines are now offering that. It's not for everyone, but it can be really helpful. And FDA indications in general, and we tend to use wave optimized. There's these different terms, but essentially it just depends on how much they're based on measurements versus the refraction. And then that's how the laser works. So it's just, that's all that means. And at the indication, so patient has to be 21 and older with stable refraction. And this is what I use, myopia up to -14. I never go up that high, probably -9 something is the highest I've gone, or hyperopia, I never go up this high, probably like +2, +3 maybe. Astigmatism, I go up to like +3, so these are like the FDA guidelines, but you'll find if you do this enough that some things just work better than others. And then PRK is just without the flap. So LASIK, you make the flap. PRK is just surface ablation. You can see the difference here. And this is really good tool. I still use it. So the downtime, the healing time is faster. The healing time is slower. The visual recovery is slower. So patients that are in a hurry, not good for them, but it's in a way safer. You don't have a flap to deal with. So anytime you have a flap, you can have things growing under the flap. You can have someone pulling their flap when they rub their eye. So it's, my wife wants to get LASIK or PRK. I told her, let's just do PRK. I do tons of LASIK. I'm very confident with LASIK, but if I'm going to do it on my own spouse, I don't know. Less things can go wrong with PRK. That being said, I had LASIK done, so I trusted enough. I've never had a complication with LASIK ever, but it's a theoretical risk I always worry about, especially if the person's very active and they're getting things thrown at them or their eye and stuff like that. So that's kind of just what you need to know. And there's certain patients that I don't even give them the option of LASIK, epi-LASIK being PRK. Sorry, so this is PRK. So I don't give them the option of LASIK because they have a lot of surface disease, ABMD. This increases the chances of epithelial ingrowth and other complications with LASIK. So I do PRK for that. Or they're a Marine that's fighting in combat situation. I've had that, PRK, anything like that. I do PRK. Or sometimes they're too thin for LASIK. Their cornea is too thin. And
Joaquin, a quick question came in.
Yeah.
For a post-cataract surgical enhancement, do you prefer PRK or LASIK?
I generally, if they're a candidate for LASIK, I do LASIK because it's faster. These patients are already unhappy, because they didn't get the result for the first time. Hopefully not. And the way we prevent it from being unhappy is because it's part of their package to do an enhancement. But some of them, they'll be a little antsy. You want to give them a quick outcome. And LASIK's super safe. It's just in some of these off cases, these are usually older patients. They're not out boxing. So, I do LASIK with a small diameter flap. It works great. Now, if they're not a candidate, then I do PRK. They just have to wait a little longer. That's all. And they need to use drops for longer too. LASIK drops are for about a week. PRK, my drop regimen is about 2 months because I really want to prevent haze formation, especially down here in Florida. So one's more involved. So I tend to do LASIK when I can. Implantable columnar lenses. So these are those myopes that are like a -14. That's when I do it. So you don't want to ablate that much tissue. They're not a candidate for LASIK. These patients can have a really good outcome. Their vision, arguably, if you do this right, is better than any LASIK could give them because you're not touching the cornea. So it's a pristine cornea, pristine ocular surface, and you're just adding a lens underneath. So the lens goes in the ciliary sulcus. So, basically right behind the iris. Okay, think of it that way. So obviously the surgeon has to take care not to touch the lens while implanting it. It's actually pretty safe if the surgeon does any amount of these, like a good volume, they'll do a great job. But there are some problems that can occur. So you got to be careful. Obviously, this thing being so close to the lens, you could get cataract. Being so close to the iris, if they're not screened properly, they don't have a proper anterior chamber depth, they can go into pupillary block. That's why we usually make iridotomy. So there are things to consider, but make sure if you're gonna send your patient for one of these, that the surgeon is well versed in doing it and does the proper preoperative evaluation. But I think it's good, and I'm kind of holding off on some of these patients right now because there's a version in Europe that has a central hole right here, and that prevents a lot of issues with pupillary block. So that I'm personally, even if I get one block out of 50, that's too much for me. I don't want that because these are just young patients with perfect eyes. So I still do it on request, but I want this, the results of this new Visian coming out is amazing. So I'm waiting on that personally, but everyone's different. You can perform touch-ups later with LASIK when there is residual error, but now we have the toric version. So that's becoming less important. All right, so refractive lens exchange, obviously, just think of it as these are the older patients that come in for LASIK, but they have cataract or even slight cataract, doesn't even count as cataract, but there's some lens changes. I'm going to push them towards refractive lens exchange. And also because their goal is presbyopia. They're correcting presbyopia, right? So what are you going to do with LASIK? Well, if they don't want to do monovision, then there's only one other option, and that's refractive lens exchange. You have to put in a lens that gives them near intermediate distance. So I'm sorry this font came out so small, but essentially it's cataract surgery before a full cataract. And I like to use for my cataract surgery as well as this, the LensR system, we use it, which is really, it makes the surgery simpler, safer, and it's really great for astigmatism management because it tells you exactly where to put the toric. I love it. So basically, these are patients over 40 that are developing presbyopia, or they're patients with kind of abnormal corneas or very thin corneas that you can't do LASIK on. For really young patients, I don't like refractive lens exchange because there's a high risk of retinal detachment. So for those, I'm thinking ICL is a better option. Monovision is always an option. The patient just has to tolerate it. You have to prove that they like it before I do it. And what I tend to use for a lot of patients, I've had super happy patients like this. So I tend to use these two Alcon lenses a lot. And there's the Symphony and there's all these lenses. They're always a new lens every year. Okay. But right now, these are my number one, number two. The PanOptix is a trifocal lens. It has this area here. These different rings basically correspond to 3 different focal points. So this is the distance area here. But basically, you have 40 centimeters, 60 centimeters, and infinity distance. So they get these 3 different focal points, and that's a really big jump. It's the only trifocal currently approved in the United States from the bifocals that we had before. And I think it's really helpful because a lot of patients are on their computer now. You know, they're on their phone. That's really intermediate distance. And we weren't able to offer them a really good intermediate option that also gave them near vision and distance until now. So I use this in patients with really good eyes, you know, good corneas, minimal dry eye or that's been treated, good retinas. These are the patients I use it on, and it works really well in these patients. And you got to set the expectations. You know, you will have some halos. So tell them that ahead of time. And then what they'll say is, oh, the halos aren't so bad. It's all about setting expectations. And the Vivity here on the right, this is a really good lens for patients that may not be a candidate for the PanOptix because they have a little irregularity to their cornea. This lens is more forgiving. The downside is it's not as good for near. So it'll give you excellent intermediate and distance, but not as good for near. So I tend to do a little bit of a blended vision approach where I do one eye aim for distance, the other eye aim for -0.5 or so. And I tend to get these patients to about J1 or J2 with that approach, but they definitely get better near with the PanOptix. So this is a patient that either is not a candidate or they say, I don't really do a lot of fine work. I do stuff on the phone, on my phone and stuff like that. And I really value my night driving and I don't want any halos. This is the patient where I would do that. So that's kind of how I think about it. And just so you're aware of how the surgeons are thinking about some of these options. And like I said, at our center, we tend to include LASIK enhancement as part of the package, because I think this is really, they're paying for an outcome. And if you're off with the refractive target, that's, even if it's not your fault, it is your fault. So because you will be off, because some eyes are really weird, and no matter the formula is calculated perfectly, but somehow they're a -1. How did that happen? It happens. So you got to have a backup plan. And this is where your relationship with the surgeon is super important. Talking to them, how are we going to handle these cases? Who are you going to refer them to for enhancement? When do I send them back to you? These are all super important questions to ask if you're working with a surgeon. So we got through refractive surgery. Anything about that? And how am I doing with time?
We have about 30 minutes left.
Okay.
And there is a question. What's the power range of ICL?
So right now, ICL is only approved for negative powers. Okay. So meaning myopes. So it's not approved for hyperopes. In Europe, it is. So it's only myopes. And currently the lowest range possible is about a -3. So basically like a patient that's like a -3 myope, basically a lens for that. Up to until about, I'm forgetting the upper range because I never had to use it, but it's up there. It's like -15, -16. It's pretty high. I'm sorry, if you email me, I'll get back to you with that. I don't remember off the top of my head. Usually the patients I've done it on are like, -12. It's definitely approved for that. -11, -10, but it goes up higher, and I'm pretty sure it goes up to like -16. But I'll email you the answer to that question, or you can just Google it. Yeah.
And talking about time, let's be about 30 minutes. Doing great.
Okay, great. So these sections are going to go fast too. So the next one is corneal ectasia and crosslinking. So what is corneal ectasia? This is, again, another topic I think is important to talk to you all about, because you're the ones that see these patients first, especially if you're doing pediatric cornea, pediatric optometry, or even if you're just seeing patients that are post LASIK, so you're going to catch this first. So it's super important for you to know about it if you don't already. So corneal ectasia and crosslinking is the topic. And what we're talking about here, what is ectasia? Well, it's really a weakening, and it's a weakening that's occurring from Bowman's membrane and the stroma. And why is it happening? Well, there's a lot of theories. We won't get into that too much, but it's happening. And it's happening in patients that rub their eyes, and it's happening in patients that have atopy or floppy eyelids more often, patients that have Down syndrome. It's happening in certain patients more than others, and especially in LASIK patients that too much stroma was ablated. Back in the day when they didn't have all of the data, and all of a sudden their myopia is increasing, their cornea is bulging out, and they're thinning. Okay, so that's corneal ectasia, and that's what they are. I make these two in bold, keratoconus and post-LASIK ectasia, because those are the ones that are FDA approved indications for crosslinking. And crosslinking is a technique that came out in the late 2010s, I believe it was FDA approved 2018, around that time. And basically, maybe it's 2016, I'm in 2016, but it's been approved for a few years. But it's been a game changer, because these patients normally you just watch them and then they need a full thickness transplant. And that's not the way to go, or they would perforate. And now we have a way of dealing with that before it happens. So other corneal ectasias, pellucid marginal degeneration, which is basically a mild cousin of keratoconus, keratoglobus, which is inherited, not inherited, but present at birth. So how do we make the diagnosis? Well, think about the history. So patient that comes in is obese, they rub their eyes a lot, they have floppy eyelids, they have allergies, they've had LASIK. These are all warning signs, things to think about. You look at the slit lamp and you have all those classic things that were on your boards, but that you don't always see. So, Munson sign, the cornea outpouching, and Fleischer rings, and Vogt striae in the endothelium. You can look for all that, that's fine. But ultimately, you're going to want to do a topography, and that's really going to be your diagnosis. But those things are good, so look for those. A lot of optometrists will find this on retinoscopy and ophthalmologists, because they see the scissoring reflex. So why is this patient, if it's scissoring, Why is it scissoring? Well, there must be some irregularity of the astigmatism here. It just starts suspecting in patients with rapid visual acuity and changes in their glasses prescription. All of a sudden, their astigmatism's gone up in like a year. That should never really happen. Or their myopia is progressing rapidly, like more rapidly than you would think. So these are all warning signs. And an autokeratometer, even if you don't have a topographer or tomographer, just get an autoK, write those numbers down, because you can see a lot there. You could just see the, what is the average K? Is it like 50? That's not normal. Is astigmatism super high, or has it gone higher over the past year? That can tell you a lot. And if any of these signs come up, especially in a young patient, just refer them out. Just refer them to a cornea doctor who can do the full workup there. And if you have a topographer, great, do it. You can do most of it right there. But you want to refer them early, because these young patients, they progress quickly, especially if they're still rubbing their eyes. So you want to catch them early, because past a certain point, you can't do crosslinking anymore. The FDA approval for crosslinking, and a lot of what insurances will cover, is the thickness of the cornea has to be above 400 microns. So I'll still do it below that, but some insurance companies might not accept it. So it's important to get these patients out there. And just remember, with post-LASIK ectasia, these patients can progress at any time. So they can have had LASIK 20 years ago, and all of a sudden they get ectasia. So just be on the lookout. And these are the findings. Let's talk about the findings. So again, this disease, I think you had to have the clinical suspicion based on the slit lamp, all these other things, and your refractions and all that. But the tomography is going to cinch the diagnosis. And the things you look for is localized area of steepening, thinning. So here's the curvature map. These Ks are super high down here. So this is not normal. Irregular astigmatism, like the IS difference, you're seeing that here. So meaning inferior Ks are steeper than superior Ks, and there's specific thresholds you think about, like greater than a 1.7 difference that you can think about. But this is an obvious case, but we can talk about specific criteria. Asymmetric bow ties. So you normally supposed to see a steep axis and a thin axis, but sometimes you see the steep axis go like this, so you gotta look for that. Increased posterior elevation. That's with tomography only. These are things I look for. Corneal asymmetry between eyes. So keratoconus is a bilateral disease, but it's asymmetric. So you'll probably see some signs of keratoconus even in the other eye, even if they're 20/20 best corrected. And if their other eye definitely has keratoconus, there's some signs usually in the other eye. And these are some of the displays on Pentacam that I use. I'm not going to get too into this. If you have a Pentacam and you want to know more, please reach out to me. But I do things like the ABCD staging, where it looks at the anterior curvature, the posterior curvature, and it grades it based on age, control average of patients. The thinnest area of the cornea. So that's a nice tool. This Bellin-Ambrosio chart is really cool. It looks at these different, basically red is bad. So in short, so this is a normal cornea. All these little boxes are averages, like the thickness, the posterior curvature, the anterior curvature, the progression of how thick the cornea gets from middle to periphery. All these things are, if they're in the white, that means they're within normal limits for that age. And if they're yellow, it means caution. Red means probably there's some ectasia. And this is the average of all of them. So if you're going to look at one thing, just look at this. Red means they definitely have something going on. So, and if they've already had LASIK, this will probably be red already. It doesn't work well if they've already had LASIK. But it's a really nice printout. I can get more into it, but just let me know if you want to know more. This is a cool one because it tells you the difference. You can put, if you have a Pentacam, you can put one date, like this was from a later date, and then you could put an earlier date. And sorry, it's the other way around. This was a later date, this is the earlier date. Okay. So you put the two together, and then it tells you the difference. So this gives you the progression. So look, between this time period of 5 months, this steepened. This is the difference map. So that's cool, because then it just tells you, okay, there's definitely change here. Because sometimes it's hard to tell that just from looking at two of these images, but the difference map helps, or even writing down like the baseline values for the first exam, and then kind of having something to compare it to, so you don't have to look through 1,000 images every time. these are ways to track it. These are some emerging diagnostic tools. A lot of cornea specialists don't even use this stuff, so don't. But if you have it, it'd be cool because to think about, because I have seen some optometrists that may not have a Pentacam, but they have an OCT. And like the Optos, some of the OCTs now, they have epithelial thickness mapping. So if you go to the anterior segment OCT and you go to pictometry, you can look at epithelial thickness. And this is a really cool area now of research where we're finding that in areas of steepening, like usually with keratoconus, you see the steepening right here, you often see areas of decreased epithelial thickness. And I think it's because the cornea is trying to maintain the theory is that the cornea is always trying to maintain its optical properties and stay like a sphere. So if it's outpouched in one area, then it's going to compensate by taking out some epithelium there. So this could be one of the earliest signs of keratoconus, actually. So it's really, really cool stuff, really good research coming out of there. Whereas EBM, if you see the opposite, you see thickening here, you know it's not keratoconus. It's probably EBMD. It's probably hypertrophy of epithelial cells. So there's a lot to this. There's corneal biomechanics now. So a lot of research going on, just so you're aware of it. And so what's cross-linking? Well, it's inducing chemical bonds between adjacent fibrils in the stroma. That's what you're creating, cross-links. This is a natural process that happens over time. As you age, you get a lot of UV light, and that UV light starts creating these cross-links in your cornea. Your cornea gets stiffer. But we can make that process even faster and kind of stronger by adding B2 drops and intense UV light to induce this chemical reaction. And that's what we do with cross-linking. So it's the only effective medical treatment for halting the progression of keratoconus, supposedly ectasia, and it can prevent the need for corneal transplantation. It can flatten the cornea and improve vision and improve contact lens fitting. So these are all nice things about it. When do you cross-link a patient? Any patient with signs of progression. So if they have stable keratoconus, if they're 80 years old and they have some inferior steepening and you see it, but their refraction's the same, you've monitored it, it's never changed, that's not a cross-linking candidate. A cross-linking candidate is someone with unstable keratoconus or unstable LASIK ectasia. And the signs of progression, we already went through a bunch of ways that I see progression with all those maps, but what insurance is going to cover is a lot simpler than that. And it's based on the following. A diopter change in the K-mean or the K-max, and you can get that either, well, the K-mean you can get just with auto K. So you can even determine this if you wanted to. A greater change in 1 diopter in astigmatism, or a change of 0.5 diopters or more in of myopia in the MRX. So obviously there's going to be patients that have a greater change than 0.5 diopters in myopia because their myopia is getting worse. That's not necessarily keratoconus, but if you have the signs, if you have the topographic evidence and you have this, then they can get cross-linked and get, and insurance will cover it. Progressive thinning. This is not usually like one of the indications for insurance, but this is something I use, obviously. So young patients are at high risk of progression. We need to treat young patients ASAP. And I already mentioned about post-LASIK ectasia. This is what the cross-link cornea looks like. So you have these additional little cross-links in the collagen fibrils. This is the Avedro machine, the FDA-approved epi-off cross-linking. The epithelium is removed first. That's the way we do it, and that's the only FDA-approved way right now. So unless you're in a clinical trial, you can't do the epi-on. And so far, I'll mention that if you keep the epithelium on in the non-FDA-approved version, they're working on it, but none of the studies yet have shown it's better. So at the very least, at the most, it's equivalent, and it might be worse in terms of efficacy. We don't know yet, but so far, none of the studies have shown that it's better. The only way you could argue that it's better is that you don't have to take the epithelium off, so patients are less likely to get an infectious keratitis. So that's probably that's the big argument. And then it's also more comfortable. And if you have young patients that don't want to tolerate epithelial removal, so it makes sense. I'm not saying there's no role for it, but right now, epi-off works, and we know that. This is the protocol. So you remove the epithelium. You start up with this brush here, or this spatula here, and then you start adding the drops after you've cleaned the eyelashes and all that. And then once you take off the epithelium, you do the drops for 30 minutes, and then you do UV light for 30 minutes, also instilling the drops during this time. And this is sort of the settings that we use right now in the Avedro protocol, the FDA approved protocol. It's a pretty boring procedure. So I tell the patient to bring headphones. Then they get a bandaged contact lens and an antibiotic drop. So I've had the fortune to be able to have worked on some of these patients even when I was at Columbia University as a resident, and looking at the earliest patients that had cross-linking in 2008. And we had the longest term data at the time, or one of the sites with the longest term data, and we looked at it and it works. So changes in Kmax from baseline, these are the months here on the x-axis. And this is the treated eye in gray, the non-treated eye is the control. So the Kmax, the steepest of the cornea, definitely flattened. So starting at 6 months, flattened. So you're flattening by about a diopter and a half, even 2 diopters you can get of flattening. This could improve vision, actually. It's not the purpose of cross-linking, and I tell patients that is not to improve vision, it's to stop the disease from getting worse. You'll still need a scleral lens, or now they have LASIK you can do on top and all this stuff that is available. But usually I just tell them you're going to need a lens for best possible vision. But more importantly than the vision right now to think about is that this doesn't get worse to a point where you're going to perforate or need a transplant. So that's important to tell the patient, what is cross-linking for? And this is the vision. So we did find, even though I just said that, the caveat is that the vision does tend to get a little better because the cornea does flatten a little bit, and this happens later. So we found that the cornea flattens even into year 2 and after. There can be some changes. So it definitely works. All right. So, and this is, again, there was that difference map I was telling you about with the Pentacam, and now it's looking at it. So the patient got cross-linking here. So this is their Pentacam before, this is their Pentacam after. And now you're seeing flattening. So this is a nice way of showing how the Kmax went down, negative 4.4 diopters. It used to be 53.6. Now it's 49.2, 5 years later. So that's pretty cool. That's a pretty significant change. So how do you monitor these patients? And what do you do after the patient gets crossing? So you want to monitor them in the beginning. Well, early on, you got to take the contact lens out. You get a month 1 exam. But then after that, you're doing it about every 3 months in the first year. And you're not really looking for much. You're just making sure the patient is happy. You're making sure there's no haze formation. You're making sure there's no infection early on. But there's really not much to it. But around 3 months is when you can start considering contact lens again. I think by then the cornea is flattened enough. It's not going to change your prescription that much, although it may over time. And the chances of haze are decreased after 3 months. So that's a good time to start thinking about it. Tell them they're going to have discomfort. The epithelium is going to grow back in 2 to 3 days, just like PRK. So they're going to have some discomfort in that time. And once they're stable and you show that in Pentacam after cross-linking, they don't have to be seen that often. I mean, maybe year 2, Q6 months, and then after that, every year. So what are the risks of cross-linking? Infectious keratitis, although it's rare, if you do it right, you clean eyelashes, it's pretty rare. And this is where the early, if it's going to happen, it's going to happen in the first week. It's going to happen in the first few days. So if they start having worsening pain after day 3, that's a concern, because that's the time that they should re-epithelialize by, around day 3. So if all of a sudden their pain starts getting worse at day 5, you probably have to see them or send them to the surgeon. So DLK in post-LASIK ectasia eyes, that can happen in the flat. That's been cited. Recurrence of ectasia. So it could come back. Cross-linking can come back even after cross-linking. The rates in the literature are about 0.5 to 23%. And they may need a retreatment. I've never had to do a retreatment, but it could happen in the future with some of the patients I've done. And there's persistent haze is rare. You do get haze in the beginning, especially in the first 3 months. That's actually fine to have some haze. That means the treatment actually worked. But if you keep having haze after that, you can get a drop in visual acuity. It's rare. make sure these patients are using sunglasses and stuff when they're outside. All right, so that's ectasia and cross-linking. And we're going to move on to our final section, which is going from front to back towards the back of the cornea, talk about the layers, and talk about some options to transplant the back of the cornea.
Actually, before we move on, there were a couple of questions that came in.
Uh-huh.
Are bandaged contact lenses being used for the first several days post-op?
Yes.
Okay.
So bandaged contact lens right after the procedure, you can take it out anytime from like day 4 to day 7.
And any experience of Bowman's layer transplant or collagen intact keratoconus?
I don't do intacts anymore because it doesn't really halt the disease process. And I had a patient that just now, I just took out the intacts patient from 10 years ago, but the intact started eroding through the cornea. And actually this was done for myopia, but it started eroding through the cornea and she was about to get an infectious keratitis. So I had to take it out. And I don't know, I'm not a huge fan personally, but I know that some people are. I don't think I think cross-linking is the way to halt the disease process. If you're talking about vision, that's where the intacts comes in. But then I would probably be more likely to do like a topographic guided ablation, which there's good literature that you can do that after cross-linking, than to do intacts. And I often just tell these patients that to get the best possible vision, they're probably going to need a contact lens.
Hey, Joe, this is Greg Caldwell. Hey, Doc. I wasn't at the beginning of but I'm here now.
Great.
I have a question. How quick after cross-linking can we fit a scleral lens?
Sure. I would say 3 months. Because if you notice from my charts there, my graphs of the patients, you got a lot of changes the first 3 months. So let's just see here. Kmax. I mean, here you're even getting changes at 12 months. Okay. But basically, if you look here, the Kmax, it actually steepens in the first 3 months. So, and if you look at the vision, it actually gets worse before it gets better. You get some temporary haze. The vision gets worse before it gets better. So around 3 months, you're starting to get, you're going downhill now. You're getting better. So 3 months, and it's also the time where you're less likely to get haze after 3 months. So you don't want to be putting foreign bodies in the eye around that time. So I think 3 months is sort of like the time, that I would prefer. It's not to say you can't do it earlier, but that would be in my opinion, the optimal time to wait.
And what is the oldest age that cross-linking is going to help? This is another question.
Oldest age?
Yeah.
It'll help anyone. They can be really old. They can, if they have post-LASIK ectasia. So like I said before, the chances of a keratoconic patient progressing at a late age is low. They can have keratoconus that's been stable because now they've been naturally cross-linked. So they're like an 80-year-old that you look at their Pennicam, they're like, oh, they had keratoconus, they have some steepening, but they're probably not going to progress. Their prescription's probably not changing. So I wouldn't cross-link them. Not to say you couldn't, but I wouldn't because there's no progression. But the post-LASIK ectasia patient, that can happen anytime. So you can have an older patient, all of a sudden they start having these signs, these symptoms of ectasia. And that's because they had LASIK and that it can just destabilize the cornea basically at any time. But again, that's why LASIK screening is so important, going back to this, because if you do it right and you look at these maps on the Pennicam and you weed out the patients that shouldn't get it and you look at the corneal thickness, the incidence of LASIK ectasia is extremely low, especially using modern femto flap creation and all this other stuff. If I'm ever in doubt, if it's borderline case, I do PRK. PRK is going to ablate less tissue because essentially with LASIK, you got the area of the flap, which is about 120 microns where you make the flap. That's all destabilized tissue. But PRK, you're just ablating the surface. So that's if there's even a question of possible early keratoconus, I'm probably not going to do anything. But if I'm going to do something, it's going to be PRK. And that's where you really have to be really, really strict, in my view, and conservative. Because whenever you get a lot of the post-LASIK ectasia you see now, if it was done with the keratome, it was done a while back before they even had these protocols. or unfortunately, it was done at one of these mass production LASIK centers, Groupon centers that do your LASIK for $200 type of place where they're not really screening appropriately.
Hey, Doc, one question or one comment I want for the audience to hear out here is, when it comes to cornea cross-linking, we're all in this whole anti-aging. We're always using antioxidants. We're trying to avoid oxidative stress in the eye. This is actually taking that type of science to the next level. And what I want the audience to realize is you take riboflavin, which I believe is vitamin B. You can help me out with that one, Doc.
Yeah, vitamin B2.
Yeah, it's B2. And you soak that cornea up, and then you're hitting it with ultraviolet light for what, a half about
Exactly
a half hour, right? So you think about it, guys, what we're doing here, we all see those pictures of people that are out in the sun for years and they're 50 years old, but look like 100. But then you have the people that avoided the sun and they're 90 and they look like they're 50. What we're doing here is actually taking and aging that cornea in a sense by taking riboflavin, hitting it a half hour with ultraviolet light, creating that oxidative stress and that cross-linking. So we're kind of using something that's kind of negative in life and using it as a positive here. So
that's exactly right. That's a great way of thinking about it.
Well, we're down to our last 5 or 10 minutes, so I think.
Okay. All right. Well, let's do some cool videos then in here. We'll go through this quickly. So layers of the cornea, we all know the layers. So let's just move on. So there's different types of transplants, and full thickness, bulk. So this is DSEC. You're adding on more tissue than you're taking out. This is Dmacc. You're just transplanting the endothelium and decimes and artificial corneas. So there's indications for all these, and you got to figure out why you're doing it as a surgeon. So obviously, if it's a full thickness problem, you're going to be doing this, right? If it's just a pump function problem where they have swelling, maybe I'll do this. So that's kind of the thinking behind that. And
Doc, hey, maybe you cover this during the talk, but I know that you can put that wrong way in. So what's the challenges? Obviously you can put the endothelium up against the stroma, and that's not good. So how do you keep that straight during surgery?
Well, the way I do it, and the way a lot of surgeons do it, is they get markings on the tissue. So you can do like a 1-2 mark or 1-3 mark where it's like a clock. So you want the 1 to be left of the 2, or I guess counterclock. You want the 2 following the 1 in a clockwise fashion. So you can make that type of mark on the periphery, or you can do an S stamp or an F stamp. So that it should look like an S, and that means you put it in the right way. And if it looks like a Z, you put it in the wrong way. So there's markings. That's the best way to do it.
And I think a lot of people that are out there, wonder how that, that graft sticks. And, is it, you don't have to suture it in, you put the gas bubble in, but isn't it the endothelial cells just kind of pumping that out, kind of sucking that all up in there? And that's why you don't need stitches? Exactly
right. So the bubble's just pushing it up against the stroma. Once, those endothelial cells start pumping, and they end up, it's like creating a negative pressure. They start pumping the fluid from the cornea into the anterior chamber, and it just sucks itself up to the stroma by doing that. It's like a little leeches working, and that's kind of how you should think about it. But the bubble is needed. And I use for DSEC, the mechanism is a little different actually of the sticking if you want to get more into detail, but I use an air bubble because the mechanism is also, there's an element of fibrosis. So the stroma to stroma contact, and there's an element of fibrosis that helps it stick initially before the pumps work. So I just use, to get that fibrosis, it'll happen fast, and I just use an air bubble that lasts 24 hours. For Dmacc, I use a gas bubble that lasts like 4 or 5 days, because the only way this works is by the pump. There is no stroma to stroma contact. There is no fibrosis. It's just the pump function. So I want that bubble to last longer, and that's why I use gas. So there's all these little nuances to it.
Great. I got a request here. Someone wants to take a look at the video. So
yeah, let's look at the videos. So endothelial failure, what are the causes? Fuchs and bullous keratopathy are the 2 main ones. That's what I use. Fuchs, this is what gutata is. The decimes comes out through the endothelial cells. That's what you're seeing. So these little excrescences of decimes. It can be sporadic or also dominant, Fuchs dystrophy. And that's what you're seeing here in the spec, that excrescence of decimes membrane. Sometimes you just have haze and Decimase, and it's not even, it's like diffuse cuttata, basically. You don't even look like cuttata. But the biggest thing here to look at for the symptoms, patients that have morning blurriness, that is the number one thing. That means their endothelium is decompensating. Dry eye patients, their vision gets worse throughout the day. Fuchs patients, their vision is worse in the morning. Their eyelids are shut, the tears don't evaporate, and it creates swelling of the whole cornea because their pumps don't even work well. And then that gets later and later throughout the day that their visual recovers. So they're like, oh yeah, my vision's always blurred for like 5 minutes and it gets better. Now next year, oh, my vision's like taking like 30 minutes to recover. That's when I do surgery. All right. So when they have symptoms. And the questions for surgeons is, do I do cataract surgery with an endothelial transplant or just a cataract surgery or just an endothelial transplant? I'm going to move a little faster here. Bullous keratopathy, you're going to see it in patients with tubes because the aqueous flow is disrupted. They hit against the cornea, especially long tubes like this. This is going to give you a corneal transplant. I guarantee it. In anterior chamber IOL, it's very close to the cornea. Most likely they will decompensate. Sometimes they can last a long time though. And you have DSEC and Dmacc and full thickness PK for full thickness scarring. I already talked about, this is what DSEC looks like. And this is what Dmacc looks like. Oh, sorry. A 1-to-1 relationship. So clearly this gives you better vision. But you're not always, it's harder to do surgically and not everyone's a candidate. And not every surgeon is comfortable doing it. So these are some pros and cons to the two. And I do both of them, but I always try to do Dmacc when I can. And this just talks about the differences and the outcomes. Basically, there are serious advantages to Dmacc, including most of which being the visual quality is better, but not everyone's a candidate. So this is a video of a Dmacc surgery. So I put in the IOL there, the cataract, this is a combined procedure, a triple procedure. So I put the lens in there for cataract surgery. Now I'm making the peripheral iridotomy, which is important because when you put that bubble behind the iris, in front of the iris, it can go behind the iris and it can create pupillary block. So you really got to make a good inferior peripheral iridotomy to allow an exit valve for the fluid so they don't wake up in the middle of the night with a pressure of 50, which can happen with a bubble, especially with a gas bubble. Now I'm stripping in a circle the Decimase membrane to take it out. And then I usually get the forceps and I basically pull it out in one sheet. It's great to get it in one sheet. Sometimes you don't, but you want to basically pull it out. And now I don't do this anymore because it comes preloaded, but this is when we used to prepare the tissue ourselves. So we have the corneal scleral rim from the donor, and then I would fold the tissue in a trifold. This is how I used to do it, but I still think it's a good video because then you can see you can appreciate the thickness of the tissue by watching this. It's very, very thin and it's like saran wrap. And that's why it behaves a little weirdly inside the eye sometimes. It can shift and turn and fold. And that's why some surgeons won't do Dmacc because there's a steep learning curve. Let's just say that. There's a steep learning curve. And I was lucky enough to learn it in fellowship, but it probably wasn't even out when a lot of surgeons in your area did their cornea training. So it's hard. But once you get through the learning curve, I think it's really great procedure. So I used to basically do a trifold, and then I would do it this way. I would pull it in across the eye. Now I inject it into the eye and it's already prepared. So it's a little different than this, but this is the way I used to do it. It worked very well, but the way I do it now is even quicker than this. Well, this video is sped up, so it doesn't happen this fast, but you can get an idea of what that looks like. So I'm pulling it in and you have this flimsy tissue in there. So the nice thing, I have this cannula that actually injects, this is actually a patented device, that injects fluid. So it helps open it up. You can inject fluid as you pull it in. So it helps unfold it. And it doesn't always happen this fast, but it's really great when it does. So it's already open. And there's my 1-2 mark. So if you see there's a 2 mark at the top left of the graft and there's a 1 mark at the bottom. So I know that it's oriented properly because there's a 2 mark here. And I think the 1 mark was here. And then I put an air bubble underneath and I make sure that it's not full so that the PI can be cleared so the fluid can get through. That's like a nice size area. And there's an F stamp, so you can see it's on the right way because you see an F. So that's basically the procedure. And now I'll just mention one more thing before we go, that there's a new way of doing things now for Fuchs dystrophy, where it seems kind of like, why didn't we think of this before? But just stripping Decimase, just strip it and let the peripheral cells come in and do their job. That's called DWEC and DSO. Now, this is like totally new. I've done 3 patients so far, and not a lot of people do this yet, but it's gaining steam. You just have to pick the right patients. Patients that have central guttata that is visually significant, but not really swelling of the cornea yet. Just like central, really dense central guttata where they can't, it's messing up the optics. You can just strip it, but you had to tell them this is going to take like 2 months for it to heal, if it does. So it definitely is a long healing time. But they can get 20/20 vision. I usually make a small little rexus. So this picture's taken about a week or like 2 weeks out. I made you could see exactly where I made the rexus because this is where the edema is. So this patient does not have good vision right now, but eventually this gets smaller and smaller as the cells migrate in. And the advantages are they avoid a corneal transplant. They don't have any foreign tissue. They can get 20/20. The disadvantages is it doesn't work well when the guttata is everywhere, where there's edema. It takes longer to clear, and you may still need a Dmacc if it fails. And there's about a 20% chance of that. So it's cool. It's great for some patients. It avoids some complications of patients, not for everyone.
Do you, after you do a DSEC or a Dmacc, do you keep them on a drop of steroids kind of for life? And then if the answer to that is yes, with this procedure, they don't need to be on a drop. Is that correct?
Correct.
Because there's nothing to worry about rejecting.
That's another advantage of it. So yeah, for DSEC and Dmacc, my protocol, I hit them pretty hard with steroids at first, and I keep them on 1 drop a day at least for a year. And then sometimes I consider dropping the steroid well, I do this with a lot of my optometrist colleagues, so they actually have developed a way of doing it. But basically, I can switch to like a lighter steroid, like an FML, keep on 1 drop a day of that. Then you have a decision to make after about a year or 2 years. Like you can just stop them on the steroid, especially with Dmacc that rejects less. You can just stop the steroid, and about 95% of patients will be okay and they'll never reject. But then you get that 5% that do. So I always try to just keep on something, like just maybe 1 drop every other day of like FML, and sometimes or every 3rd day, and that's enough. That's usually my go-to. For DWEC, there's no transplant, there's no foreign tissues, so the post-op drops are just like cataract surgery, with the addition of 1 drop that I use to improve endothelial migration. It's a rho kinase inhibitor. So there's that drop, and then there's the regular cataract surgery drops, and that's it. So that's it. That's the whole presentation. We covered a whole lot of stuff. Let me know if you have any questions about anything.
No, I think you did a fantastic job. You went coast to coast on that one. There's a lot of material, and we certainly really like it. It was terrific. We have a question. What do you recommend for your grafts getting vaccinated? Any change?
That's a really good question, because I'm on a few groups of cornea specialists right now, and we're all noticing that after vaccination or COVID, we're getting some patients that reject. So especially those patients that I was just talking about that we've taken off the steroid drop, or someone has, sometimes they come back and also my vision's blurry 2 weeks after, and they have some KPs, they have some Decimase folds. There's a higher incidence we're finding of rejection after COVID vaccination. Usually it's reversible. You just have to start them on the steroid drops and hit them hard with them. But yes, we're finding that. So the question is, what do? Do you try to call up all of your DSEC and Dmacc patients and tell them to be wary? Maybe. I'm not sure what the right answer is. But I've always instructed my patients to come in if their vision changes at all. So, or if they feel light sensitivity. So hopefully that's enough for now. But I don't think it happens in everyone. It's just kind of like how this COVID virus some people react to it differently than others. And I think it's related to your immune system and how strong of a reaction you get. But so it's hard to predict who's gonna have an adverse outcome to it or not, but it's definitely there.
For corneal edema and Fuchs, do you prefer mural drops or ointment?
I prefer ointment because with Fuchs, the blurriness is worse in the morning when their eyelids are shut. So I would say that I definitely do the ointment at night. I definitely do that. And then I'll also do the drops if the patient likes them, but the drops don't work for that long. So I'll do, you could do like the ointment at night and the drops 4 times a day during the day. But I'll say this, I mean, there've been studies about this. The Muro, it's kind of like a Band-Aid. It'll help dehydrate the cornea a little bit. It's not going to change the disease process, obviously, and there's going to come a point where the Muro doesn't work. And honestly, the Muro tends to work better before there's frank corneal edema. Only when it's like subclinical corneal edema, that's when it tends to actually do something. And there's been studies about that. When there's frank edema, a lot of defaults, like thickened cornea, it's not going to do much. So.
Well, thank you so much for doing that, Dr. DeRojas. That was Cornea Copia by Joaquin DeRojas, a corneal specialist with us at USI and Center for Sight.